Excellent. Okay, well, it is just after 1 o'clock when we're due to start, so we will be commencing. So my name is Cookie Taylor. I work for Doctors in Distress, which is the charity that has put on this webinar, which is being recorded, as I say. And I'm here with my colleague Aileen, who is our communications lead, who is going to be helping out as well with the session. We are so happy to have everyone who's decided to join us during their lunch period. You will be able to remain anonymous. All we ask is that it remains as interactive as possible. The way we're going to do that is through 2 polls, or 1 combined poll, and 2 questions in the chat box as well. So when those questions do come up, please do just go with your initial gut feeling. Don't sort of pontificate about what you may or not want to articulate. Just go with your gut in responding to the question, and then we can relay the results. Again, everything will be anonymous to the panel and to the rest of the people who are participating. I think we have some people from all over the globe. Thank you again to Dr. Deep Sirur and Dr Sridevi Sira Mahalingappa, who is joining us from Australia, which is amazing because it's like 2 a.m. or something over there. So wonderful. So just so you know a bit more about Doctors in Distress, we are an independent charity that looks after and runs programs for the mental health and well-being of all healthcare professionals, not just doctors, but everyone across the board. Dr1in4 program is one of our programs that we run. We have had 1 previous session, and that's available online, and we're happy to send that out to you, so you can take a look at that as well. And we're going to have another session in February with Dr. Linda Gask as well. So Doctors in Distress, as I say, is an independent charity. We run programs that are both peer-to-peer support, but they also have creativity elements as well. And if you're interested in anything like this, again, please do leave your contact details and let us know that you want to be contacted to hear more about our programs and possibly getting involved. Dr1in4 was set up by one of our trustees, Dr Sridevi, and indeed Dr Sri was involved in that as well. And the main learning outcomes from this program is to engender a greater culture of confidence and disclosure across medical students, in terms of disclosing vulnerability, any mental health issues, or just trying to ask for help, whether that be for yourself or for the colleagues you see around you. The way that this works is an interview process. So we've got 1 medical expert who will talk about their lived experience, and 1 medical expert who is going to be the interviewer. As it is a lived experience, I would be very grateful to have a sense of safe space for all of us, including those who are speaking, the panelists as well, because these are real life issues that are generously being shared for the benefit of all of us. If you have any questions during the session, please do add them to the chat box, and I will be monitoring that with Aileen to make sure that the key themes are being presented to the panelists so we can ask those questions as well. So we should probably kick off. One of the first things that's going to happen just before I introduce Deep and Sri again is that we're going to run a quick poll just to gauge how our audience are feeling, where you are, the context of your lives. So if we could do that now, Aileen, that'd be super. And as I say, if you could respond to the questions just as quickly as possible, the first thing that comes into your mind, that'd be great. So in terms of stress, that's quite considerable. The statistic of Dr1in4 is that, as we all know and we keep on hearing sadly, is that the healthcare profession is under increased pressure. Doctors in Distress was set up on the basis that our founder's brother, who was a cardiologist, sadly felt that he had nowhere to turn, was suffering burnout, and tragically felt that he had to take his own life. So that's the reason why we're here today, is to make sure that we can engender a culture whereby people do find a way to talk to each other, find other ways to support each other, and just can do the job that they need to do, but it's fully supported. So thank you for your inputs there. Right, onto the panel, not from me. So Dr. Deep, who is a consultant addiction psychiatrist, and he's also a named trust medical lead for adults, and Dr. Sridevi Mahalingappa, who is also a consultant psychiatrist. So over to you two. Thank you.
Thank you so much, Cookie, for that kind introduction. I and we both used to work in the same trust in Derbyshire Healthcare NHS Foundation Trust, along with Professor Subodh Dave, who designed this program in Derby. So we are very grateful for our Derby teaching team who helped us to develop this program in Derby. We ran several sessions and they were very successful. And it's really good to see that this program has been rolled on to national level. And thank you very much for all the students who have joined the session. So Professor Subodh Dave, when he first named this program Dr1in4, we all know that incidence of mental illness is very common in doctors. 1 in 4 doctors may have mental health issues, and most of the time, because of the nature of the work that we do, we don't really talk about mental illness openly at the workplace. So Professor Subodh Dave, designed this program. He invited people with lived experience, doctors who had mental health issues, to come and share their experience, talk about their impact of mental illness on their professional career, what was helpful, what was not helpful. And we also believe that it's really important for medical students to talk openly about mental illness and look at the senior professionals. And I think we should develop this culture of talking about mental illness openly at medical school or workplace. So this is the main concept behind this Dr1in4. And I'm really very grateful for Deep who has joined the session. So Deep, is it okay if I probably ask you a question on your journey into medical school? How did you, what inspired you to medical school and to become a psychiatrist, please?
Okay, thank you. Yeah, it's lovely to see you again, Sri. I think we go back a good few years, don't we? I don't want to bore medical students because probably they'd all have been like 6 or something when we probably worked together. But just before I go into that bit, it tells you what a small world it is and how prevalent I suppose these problems are. Because I was back in '96, in the last millennium, I was a 4th year medical student. And I was placed on Northwest as part of our medical rotation. And during the psychiatric attachment, I happened to be placed with one senior lecturer by the name of Dr. Gask. And we have actually caught up since then. And it was really interesting. So it just goes to show how small a world it is that perhaps she was going through things at the same time I was going through things, and neither of us would have known that anyone was going through anything. But that's that. I'm someone who can talk for England and India, so I'm grateful I've got Sri, who's probably going to be quite good at getting me back on track if I fall. So the original question, I think, was about what got me interested in medicine into medical school. So the first myth I always feel compelled to dispel is a as a BME person of South Asian origin who was born in this country with a relative amount of privilege. My dad was a GP. Is I went into medicine because I wanted to be a doctor, not because I was good at science, not because I was forced, not because I was pressured, not because my dad was employing reverse psychology to say, well, do you really want to do it? It is really quite hard work, and if you're interested in money, there are better career options for you. And I've kind of sent you to a nice school and given you the opportunity so you can choose a profession that you want to do and be happy in. And so my journey to medicine, I wouldn't say I was born to want to be a doctor, but obviously when the ideas of being soldier, policeman, airline pilot all started going away when I was about 7 or 8 years old, I realized I didn't have the skill to be a professional sportsman or an international rock star. Then I started thinking probably I need to hunker down and get a job which I enjoy. I was quite lucky. I went to a good school in my region. I've still I still live in the East Midlands. I lived and schooled in Nottingham, and I went to the local good boys school and got a lot of support. Schooling was good, fun, and there was an ethos of expectation that you do well, but also it empowered and equipped you to be confident and comfortable in yourself. Medicine probably started coming on the radar probably for the same time as most of us, I guess, when you're having to make option choices about what GCSEs. Yes, I'm a GCSE person, but they'd only been going for a couple of years. And I did, at that stage, I picked some sciences because I quite enjoyed them. Medicine was kind of on the radar, but it was, as I was kind of focusing more in my ideas of what I wanted to do, I was drawn more towards psychology, and clinical psychology was one of the things I was considering. Again, luckily I had the opportunity to get good careers advice. My dad was a local GP, so we were quite connected with medical people. And I did get some quite good advice that actually, if psychology type stuff is what you're interested in, if you're okay with blood and you can do medicine, it's a pretty good degree. And if you want to do that through that, do psychiatry, it'll give you a whole world of options and a career pathway, which is going to be probably a lot more straightforward than if you want to train to be a clinical psychologist, which is a lot more tricky, tortuous, and tough to career plan beyond the thing. The beauty of being a doctor and medical student is our career pathways now are much more structured, laid out, and it's a lot easier to do what you want to do. And the blessing now, which I didn't know at the time, is how privileged it is to be able to do your main day job, which is what we're able to do, and have add-on roles and still keep doing what luckily I still love doing. So that was my kind of thing. I did okay. I got entry into medical school, and I quite enjoyed that. And I did, but I actually went in with a view to do psychiatry. So it wasn't something that evolved during my time in med school. I tried other specialities. I kept a reasonably open mind, and I was also aware of the fact that, you know, a lot of people who love psychiatry on an intellectual basis, when they come face to face with the realities of what it's about, sometimes it's not quite as straightforward or quite as easy. And I think often as medics, we are trained very scientifically and looking in a binary fixed solution, balance of probabilities. And for me, the joy of psychiatry is how many of those variables are outside our control, and having much more of a broader thing. And, you know, for me, it's just like, I just love the principle of the fact that you can get people who've got a messed up mind for medical reasons, help them come to terms with the chaos. And we've got a reasonable number of biopsychosocial treatment interventions, which are really quite good. And also at the time, compared to other specialities, it was still a developing speciality. You know, there's been miles of advancements in the time since I first began as a junior doctor in psychiatry to what we are now. I think in the early days when I was at medical school, I think CTs and MRIs were were super sexy and exciting, and things like SPECT scans and all these things which we can now take for granted and see what chemicals are doing what in the brain were kind of there. In fact, I think we didn't even know that there was a good level of plasticity and healing around the brain when I first started. So it was something which attracted me, and I never regret my choices of being in medicine, and I'm really privileged and lucky to have been in it.
Thank you, Deep, for sharing your journey with the medical school. And I think some of the medical students may not know what Addictions Psychiatrist is. Would it be possible to share some information about that, please?
Yeah, absolutely. So for the benefit of the medical students, psychiatric training up to and including the specialization is exactly the same as your core medical training. You do your medical school, you now do, I think it's 2 years, isn't it? In our day, we did a 1-year intensive what was called pre-registration house officer to get your registration. At that point, you would then decide what you wanted to do. During my training time, things were an awful lot more flexible. So it was not uncommon for people to chop and change, do jobs here and there, perm their own VTSs. But for me, by the time I'd done my acute medicine and my pre-registration jobs, which I don't want to glorify or glamorize because it was horrible times, but you know, it was back in the tail end of the time where we still did 100-hour weeks and as routine, and a weekend on call would start on Friday at 9 in the morning and end at some stage on Monday. And if people were being kind to you, they'd let you slope off early on Monday afternoon to get a bit of rest. But that was, and then you'd probably have a break and you'd be on call again. So you know, it was in that period of time, which was a great challenge, really. That didn't actually put me off acute medicine. You know, there was a tendency back in the day that psychiatry was seen as either a soft option or a lazy option, or actually the stigma around it, which I hope is going away, but it's still there in pockets, that it's for doctors who aren't that good at being doctors. Whereas in reality, I think what we're now seeing, and is much more a thing, is psychiatrists are perfectly good doctors. And I think what we're increasingly seeing is general physicians are woefully under-equipped to deal with the level of psychiatry that is out there, and the ability to recognize it. So my journey then went into fairly straightforward. I got a nice training rotation in my hometown of Nottingham. I did my med school in the northwest, but I chose to came back because my family was there. And my football team, which is now Premier League again, Nottingham Forest, was a big part of my life back then. And during those days, we were actually a Premiership team regularly. And Chelsea and Arsenal and Man U used to be a bit twitchy about playing us back in the day. So I came back. I also had a cohort of friends who were in that area anyway. So and I always felt, from a professional point of view, it's nice to be around where your folks are, because I've always had a good supportive family and a reasonably good solid friend network. So I did general psychiatry. I had a few hiccups along the way, which probably we'll talk in more detail about when we come into my my lived experience. But eventually got the exams I needed, got a place on the higher specialist training. My original plan was to do forensic psychiatry, actually, which I did spend some time doing forensics, and I spent some time working in special hospitals and the like. But at the time, but for me, the forensic side of training was a different training number. And at the time, because I was a bit lazy and didn't really want to leave my region, I was advised, which I think was good advice, to stick around, maybe start on a general training and then look to either transfer or apply for CT, because there's this thing, and this is more aimed at the medical students. It almost feels like there's a pressure to get to a point where you achieve and you get to the consultant grade. Psychiatry, in relative terms, the SPR, the higher specialist training, is a relatively short one compared to some of them. So you spend all this time trying to get to a point, and then before you know it, you're thinking, oh my goodness, in 3 years' time, I'm going to be a consultant. I don't feel ready. I don't want to do it. So, you know, anything which might add time in at that point suddenly seems a bit more attractive. So I was comfortable with that. I thought during that period, what would be quite handy is to get a much more in-depth experience of addiction psychiatry as part of that, because I thought it would enhance, and people who are interested in forensic side of things and general mental health will know that addictions go hand in hand often with risk and management of people in forensics. And I really, really enjoyed it. And I was effectively looking at a similar type of people who probably I would have been seeing within forensics, but I actually found it much more liberating, because forensics revolves a lot around very, very high-end complex risk assessment, multidisciplinary team decisions, lots of pieces of pink paper and legislation, and now probably having to ask Suella Braverman's permission to do anything you want to do on anything to do with anyone who is remotely high risk and politically sensitive. And what I found in addictions is I could actually work with the same types of pathology and to a degree with significant levels of risk, but because of the nature of the speciality in addictions, we work very much to a behavioral model, which I think is much more now as we do psychiatry. But back in my time, it was still very much, you know, the default position was to detain people if they weren't doing what you wanted them to do and they were risky, until you worked out what to do with them. Now that is changing in a good way. But also in addiction, we're also kind of exempt from, as a hard diagnosis, it's kind of exempt from Mental Health Act type approaches for reasons which we may touch upon. So it allowed a much more collaborative working relationship with our clients. We're very much working with them, co-producing plans and developing something which would work. The evidence base was all still fairly sketchy, so you had a lot more clinical latitude, and we weren't encumbered as much at that time with targets, processes, procedures, and there was a fairly clear remit of what we did, what our role was. And what people will find in psychiatry is the beauty is everyone we saw had a key worker. So I was working with someone and supporting a nursing and allied healthcare professional team doing the bulk of the psychosocial work, and my role was much more around managing medications, primarily people who had problems with opiates, crack, hard end drugs, and teasing out how much was drugs, how much is mental health, where those two intersected. Absolutely loved it. So when it came to the time of considering whether I shifted to another speciality training, I actually thought that I'd found what I liked, and I then went on to do an endorsement in addiction psychiatry, so I could work as an addiction psychiatrist proper. Got my CCT, and happened to bump into someone who told me that there was a job going somewhere, because that's how it used to work and probably still works actually. So I snuck into my little patch of North Derbyshire back in 2007 as a locum on a out of program experience, try before you buy. And 15, 16 years later, I'm still here. And that's my professional journey.
Thank you, Dave, for sharing how exciting it is to work in addiction psychiatry. You mentioned that you had some difficulties with mental health. Would it be possible to share with our students, please, more about when did it start?
Absolutely, yeah, and that is something for me. I'm now I'm going to age myself now, so I'm going to be touching on. Well, I'm in the higher end of 40s. I'll leave it at that, because this is going to be recorded, isn't it? So I can't lie about I'm a doctor. We shouldn't be lying about anything. So what I think was, I've been on a journey, and part of my journey is actually teasing out and thinking about where and when things first started going wrong. Because one of the challenges I've found, just to be clear, I've got two major problems around my mental health. I have an underlying depressive diagnosis, which I still have, but I'm in remission, and that's managed by medication, which does work. They're not sugar tablets. They're bloody good if they're managed properly and they're taken for the right reason and done in the context of other things. But tied in with that, and this is where I think this is very difficult for people, is prior to even knowing or thinking, or maybe whether I even had a depression, alcohol was something which was part of my life initially socially, and then as time went on, increasingly more from a self-medication point of view. And at some point within that journey, my drinking and my mental health kind of all mixed in, and that's when things started getting really quite complicated, because one of the difficulties I had is I didn't really know what good mental health was. You know, now looking back, it's relatively straightforward. And this is bearing in mind someone who is a professional in the field. You know, the irony, which I hope demonstrates this is not stupidity. I've done reasonably okay in my career. I'm guessing Sri probably didn't even have a clue that I was going through mess when we worked together. Or if she did, she was very discreet about it. But I think probably around the time you knew me, I was probably senior medical management, and you know, I'd won fair few competitive tenders. I was quite actively involved in all manner of trust things and picking up clinical excellence awards here, there, and everywhere. So you know, I was not someone who was a failing doctor, but this was during a time where I was having problems, quite significant problems, and at various stages I did what I've always had the ability to do, or used to have the ability to do in the early stages, is when I needed to switch on and be present and be there, I could do that. So I did have periods where I'd do a lot of loafing, not doing very much, bit on the I thought lazy, but we lived and worked in a professional environment, I guess, where that was tolerated a lot more, as long as you did what you needed to do. You know, so the performance management elements, the stress and the pressures, which are now there in a different way, weren't nearly so prominent. You know, we had much more light touch supervision in terms, you know, we had what we called the good egg test back then. So very early on, people would make a judgment: are you a good egg? Are you a safe pair of hands? And if you kind of passed the good egg test, then the kind of halo effect would kick in, and generally, as long as you weren't doing anything messy, causing people problems, you were generally seen as someone who was okay. And that's kind of how I got on. So I did have periods of time where drink started to become a problem. It started in medical school. Initially, it was there as a coping strategy, as a mild social lubricant. Looking back, I now recognize that I was using alcohol in a way that my friends didn't. And I think the difficulty in those early stages, I don't know how prominent drinking culture is within medical school and medical students these days, but certainly during my training time, which was in the 90s, you know, it was part and parcel of, you know, the kudos at medical school was being able to get completely bladdered and still pass exams and still turn up and still do 100-hour weeks. You know, it wasn't, it was so endemic in what we did. And the, you know, the golden rule was don't break the 11th commandment, which is don't get caught and don't get yourself into trouble as a result of your drinking. So it was there, it was kind of around, but there was also, we were in much more of a pastorally protective environment, I guess, where your firm, looking back in a good way at the time, would be very supportive of you. Your consultant, even if your consultants knew you had an issue, your junior doctors, they would ask you to consider it, they would look into it, but there was nowhere near what seems to be now the regulatory and safeguarding requirements and pastoral care that would mean that a consultant would be in a whole pile of poo for not doing things that he should have done to pick up this, that, and the other. And the, you know, there was a much more of a, what we've lost, I think, in medicine now, is there was that whole cohesive team feeling within a medical firm where we all looked out for each other, supported each other. Now, in one way that was good, but in another way, what it also allowed was it allowed people to be functioning with problems. And it was a kind of don't ask, don't tell kind of attitude, unless it was getting to a point where you were a risk to somebody. So So that was the environment I came in. During medical school, you know, I was on the heavy drinking side. Over time, that increased, and certainly towards the end, I was certainly within the cohort of med students who would be regarded as the hard end drinkers. I was never physically dependent, but you know, a night out with Deep and Deep's chums would not be a night out. It would be a weekend out or longer. Because again, the nature of our courses at the time was you had various stages where you'd be assessed, have to do exams, but there wasn't that kind of continual assessment process and monitoring and performative assessments, and it was all summative. So you could mess about for a year, and as long as you got 50% in an exam at the end of it, or you passed your clinical modules. Would things have been different if I had hard end finals, which I had to pass? I don't know. But from the fourth year onwards, after I'd done my hard exams, in effect, all my credits between then and qualification were free. So I'd passed medical school in effect at by about February 1996. I didn't qualify till 1997. So then there was a summer, there happened to be a European Championship on Euro 96. Ask your parents, medical students, it was cool. I trained in Manchester in the 90s, where there was culturally a big drinking culture and other things. I luckily didn't get involved or have any problems with drugs, which was again endemic in Manchester during we're talking about times of all the culture and dances and raves and all that kind of stuff. Luckily or unluckily, I would say luckily, I'd found my poison by that stage. It was booze and it was completely legal. So I didn't really feel the need to experiment with anything else because I'd found my poison. And so I didn't have any breaks. And throughout my life, I was wishing and hoping that something would kick in which would stop things. And as I progressed through my career, and as I progressed firstly through medical school and the earlier stage of my career, the natural things that make people stop. So a big chunk, at least half of my hard end drinking friends, once they qualified and started doing work proper, they stopped, or they drank what I would call like normies. You know, they were still hard drinkers. They enjoyed a binge, but it wasn't impacting on their life. They could put, you know, if they had an on call the next morning, they'd be stopping at like 9, 10 o'clock. And because they knew, as I went through my career, I had a good friend who is a senior ICU consultant in a part of England. Very good, very able. He liked to drink. We'd have mess parties on Thursday night. And by about 9 o'clock probably, he'd switch on to soft drinks. And of course I'd ribbon tease him because he was quite a good, I say good drinker, a bad drinker back in the student days. And he said, well, yeah, I know there's a free bar, but you see, you get a line in a study day tomorrow. I've got to get up at 6 and be on the ward at 7 to prep for this list I've got to bloody do. I ain't going there knackered, smelling and missing bloody IV accesses because my hand's a bit jittery. So I'm happy to stick out, but I'm going home at midnight and I'm not drinking any more pop. Those things, you know, people drifting into relationships, people where the competitive nature of their career meant that you couldn't mess around. If you were wanting to be a cardiologist or you were looking for a high-end teaching hospital rotation, you know, you physically couldn't do that and progress because you didn't have the time. In psychiatry, I had an awful lot of latitude time-wise. That I had a 4-year period where, as long as I got exams at the end of it, I was fairly comfortable that I would then be able to get a higher specialist training job. And from there, it was a buyer's market or seller's market. I can't wait which way around, but there were more jobs than there were people to fill them. And, you know, even bearing in mind, I literally will know the region I worked in, Nottingham, it's a fairly well-regarded higher specialist training rotation. But, you know, we were at the time where there were 4 posts for 4 local candidates. And, you know, so all these things were yours to lose. So it wasn't like I had to really match fit, sharpen my CV like my friends who wanted to be cardiac surgeons who Sorry if there's anybody in cardiac surgery. I don't think it exists as a specialty anymore, so sorry. But you know what I mean? There are certain specialities or people who are driven career-wise to really progress. There are other people who just like wanted to get on with their life and saw that kind of thing as something they did. It was there, they enjoyed it. They met partners, girlfriends, whatever, had kids, wanted to spend their money on getting a nice house, progressed in their career, all these kind of things, whether they were medics, whether they were non-medics, whatever. So that all those natural breaks for whatever happened didn't happen to me, or the problem I would find is that those things which naturally kicked in, they didn't kick in for me, or they didn't. I would be getting those milestones, but it wouldn't be impacting on my lifestyle. And you know, I found myself managing my life around, at that stage, my drinking. At this stage, I hadn't a clue that I had underlying mental health problems. I was a drinker. I liked drinking. The problem I had was the problem with alcohol is it smells of it the next morning. And the problem I had is people giving me a hard time because they didn't see why I drank so much and didn't do sensible things, and why I wasn't settling down and having a wife and a kid, and why I was comfortable with a one-bedroom flat when everyone else was buying nice big detached houses and mortgaging themselves to the hilt. I didn't do that because there was enough sense in me that I budgeted how much money I needed to live a bon vivant lifestyle, which is how I portrayed it. So I kind of managed to muddle on through and bumbled my way up to a level of thing. So I did have an incident in my early part of training, probably about midway through, and that was alcohol related, where completely rightly at the time, it had been noticed by a member of nursing team who I didn't work with, but when I was on call, they could smell alcohol on my breath at about 11 o'clock in the morning. I hadn't been drinking that day, but this was clearly, I think it was a weekend, and I probably had a bit too much pop the day before. Clearly now that was completely inappropriate, and I shouldn't have been in that situation, and whoever did what they did was completely right to do that. But it then came to attention of people, and at that point there was an intervention, and it was a very positive intervention, luckily for me, because I had a good working relationship with my TPD, training program director at the time. Most importantly, I was honest. I didn't try and cover it up. I didn't say, no, it's all. I didn't make an issue about the fact how very dare they shot me in. I took it on the chin and I said, yeah, there's a problem here. And they were very good about it. And they provided me the support, they provided me the help. I got some deanery input. They were very good. I was coming towards the end of my rotation. They even agreed to extend the rotation to give me a time. But there was now a lot more at stake, because they said, we're going to extend your thing. That will give you enough time to get your head together and make 3 meaningful attempts at your exams. But after that, you're on your own. We can't extend it forever. Now, bear in mind, at this stage, most of my chums had already got their Part 2s, MRC, whatever they're called now, but they'd got their membership. I'd every now and again, I'd turn up for a multiple choice for the Part 1, and was unsurprisingly, when I was largely guessing most of the answers, I wasn't passing. But I just got onto this treadmill of pretending I was doing it, pretending I was working, and just pretending I was unlucky. But during that period of time, I did really pull my finger out. I acknowledged I had a problem, and I realized this had to stop. And it did. It stopped for about 4 years. And I did everything I needed to do. I rehabilitated myself. I didn't need to go to rehab, but I was able to stop. My mood improved quite markedly. I got my exams within 6 months of each other. I got Part 1 and Part 2. I was regarded clinically. I was liked by my peers, and everyone was really happy for me that I'd kind of got myself back on track. I'd met a lovely lady at that point who also happened to be a doctor, and we were heading towards, I suppose, life happy ever after. Job done, and I was clean. I was now an SPR. 3 years I was going to be a consultant. I'd done my bit. I had proved for 4 years that I don't have a drink problem. and I didn't at that stage feel I was particularly depressed. What I didn't know is I just adjusted to the fact that my normal was depressed. I didn't know what feeling good felt like. And I think this is something which, as doctors in particular, we tend to be on the high functioning end of stuff. So we're often in an environment. I know if people are very, I was never, the advantage I had with my schooling is, you know, good at my school was top of the country and being on international Olympiad teams or getting, you know, things to Harvard or going to Oxbridge. But being average at my school was plenty enough to get you into a good Russell group, as we now call the medical school, because I was floating around average, above average, and that was kind of my normal. And I thought, that's me. That's what I can achieve. That's what I can do. And it seems to be getting me by. So, you know, I was never one of these high achievers who was craving for honours. I needed 50% in an exam. If I got 50.01%, that was a pass. That's what I needed. And maybe because I wasn't in that elite end of an elite school, I never craved being top. So I was very comfortable in knowing what I needed to do to get what I needed to get done. And that was something I was able to do. So my normal, or what I thought was my normal, was actually quite good. What I didn't realize, what people were seeing as my normal was actually me suboptimal, but which meant, at the risk of sounding arrogant, no one ever saw my good. I'd never even seen my good. So then I adjusted to my normalcy being probably, well, I'm okay. I'm surviving. I never felt happy. I never felt I lived, you know, that feeling that when you've achieved a milestone of some description, it was the relief of achieving it, not the joy of putting effort in and achieving. There was always that imposter syndrome that, you know, I'd fluked it. I'd blagged it. You know, I still remember what I didn't know was a pass-fail Viva. And I've always felt I was lucky. You know, luck came along. I had good people in my life. I had supportive people that happened to come along. My pass-fail Viva in the third year, which I didn't know was a pass-fail Viva. I thought it was a thing. It was a liver in a pot, which was completely mangled. Now, if you ask someone who drinks too much, who's a medical student, one thing they will know like the back of their hand is the anatomy and physiology and the treatment plan and pathologies of a cocked up liver. So how lucky is that? That got me through the bit that either keeps you as a medical student and at risk of dropping out, to passing that threshold where they spent too much on you to allow you to fail, and then you progress, you know. And all along the way, these kind of what I thought was little bits of luck and being in the right place at the right time meant that I started almost believing my myth of life will work out, because it always has done, and this drink and everything isn't a problem, mood isn't a problem. And so I did the dutiful thing, as one does, that I decided I didn't have a problem. I'd done my thing. I'd achieved what I wanted to achieve. What's the harm in now going back to a little dabble of a nice glass of wine with fish? And I diligently stuck to my units to start with. I phased it back in. My partner was tentative but supportive, because she didn't know me as someone who drank. But what I didn't realize is how bloody quickly it would come back. And it came back quickly because I never drank for the right reasons. I didn't drink as a mild social lubricant. I didn't drink for a little bit. I didn't drink for the fact that I like that little feeling. I didn't drink because I thought a nice Pinot Noir was absolutely beautiful with a rare steak. I drank because I liked getting pissed. I liked to forget my life, and I you know, there's a phrase, my favorite drink was the next one. And very quickly now professionally I was able to manage that, but at the expense of everything else. My relationship suffered, my relationship with my family suffered. All of a sudden my partner, who I'd been with at that stage for about 3-4 years, and probably we were starting to think about making things more serious, met this person who was clean, sober, erudite, progressing in their career, well respected, well regarded, now turning into an alkie in front of her bloody eyes, and she didn't sign up for that. Of course, me being me, I was blaming her, because if she wasn't so bloody neurotic, I wouldn't have had a drink problem. So it was, again, I was in that phase where I am fine, life around me is crap. If people did what they needed to do and stopped bugging me, I would be fine. My problem with my drinking is the fact that you're making it a problem. And, you know, that kind of mindset kind of just stuck in there. And very quickly I was back into problem drinking again. And it was only after I had a sustained period when I stopped. And this was after fast forwarding, where I met a new wonderful lady who's now and still is my wife and mother of my kids, where she was really quite concerned that this would be a problem. And I did commit to her, if for a life moving forward, I will not miss on the head. And I did. And again, I did what the textbooks say, 4 years, didn't drink. But then I couldn't live with myself not drinking. I was in this horrible place where I couldn't drink because of the implications of drinking, but nor did I enjoy my life not drinking. And I just adjusted to that being me. And that was a horrible, horrible place. And ultimately that took me to a point where the only option I saw was to try and end it all, which I did try to do. That was back in 2017. And luckily, or unluckily at the time, I suppose, my car of choice, which was my parting legacy from my late father, was a Volvo. So if people are serious and they do want to do it, don't do it in a Volvo. It bounces back on the road and you're still with us. And also, unfortunately for me, there was a tree which I didn't see, which stopped me going into the River Derwent. So all tragic. I had a life plan and I knew what I was going to do. And when you're in that place, when you're reasonably high functioning, when you're a psychiatrist, no one will know, because you will do anything and everything in your power to stop people knowing what your plan is. My last meeting before I did this was with some senior people within the trust who are experts in mental health, risk assessment, risk management, staff welfare. And I really feel for them, because I hope they didn't feel too bad about the fact they missed something. And I've often said to people, and I won't name them, there was nothing for you to miss, because I was not going to give you the opportunity to intervene. This was not going to cry for help. This wasn't my life is shit, please help me. I'm not saying there's anything wrong with that, but this was a plan that my only option, and the only option for the people around me whose life I was making a misery, and alcohol had now crept in secretly to self-medicate, was, I think the best option is short-term pain for them for long-term gain with me not being in their life anymore. My service was as secure it was going to be. We just won a 5-year contract. Everything was ticking over. I was quite comfortable that things and places and things could function quite well without me, and actually better for me not being in the world. And that was my mindset. So people who think that suicide is an act of selfishness, in some cases it might be. It may be the only option that people see. But when it's in the context of a depressive illness, it is far from selfish. It is seen irrationally at that time as a selfless act of you sacrificing your life for the betterment of others, and not seeing a way how your life can be better in any way, shape or form by surviving. And my coping strategy had been booze. That was no longer part of the equation. So life as it was horrible, and I didn't want it anymore. And all I was doing was causing misery to other people. And that's why on one particular night, I took the decision to, whilst I was out driving, to have a tragic accident, which actually turned out not to be tragic, because luckily there was a tree. Luckily it was a Volvo. Bad news. So far so good. It should be a story of redemption. Unfortunately for me, the only time I could pick was when I was on call. the only time, and this is something which people who are drinkers fully get, but other people find us a bit skeptical. When it failed, when I was deciding what to do, any good alcoholic will tell you they'll always have a safety somewhere. I had a safety, nice little quarter bottle of vodka. So I was standing on the roadside thinking, what should I do in this situation? I needed an anxiolytic. It was a little bit cold, and I probably needed a bit of Dutch courage to take me over the edge if I completed the act which I intended to do. Unfortunately, that didn't quite work out either, because I ended up getting rather inebriated. I understand this is all stuff I heard retrospectively, because I've limited, if no memory of any of this. Obviously, I had an upside down car in the middle of the road, which doesn't go unnoticed. People came, reported it rightly. Police got involved, as did an ambulance, and I ended up in our local A&E, which is always a bit embarrassing, whilst I was on an on-call shift. Luckily, nothing I did at that time directly impacted on patient harm, which was good, but I was in a no fit state to be doing that on-call shift, and I was found, albeit upside down and not drivable, was technically in charge of a vehicle whilst I was under the influence of alcohol and drunk on an on-call shift. That is a problem. In any stretch of the imagination, that's a problem, and rightly people felt the need to involve the GMC. I self-referred myself by my medical director on his advice, but unfortunately a rather overzealous A&E consultant beat me to it. But again, they were doing absolutely the right thing. And then if I thought things were shit, then they kind of got a little bit worse, because not only did I have all the stuff I had to deal with, now it was all out there, and I had this whole other problem of how is my family going to deal with it, how's life going to happen, and where and when am I ever going to work again? I even could have been facing prison. Luckily, no one else was injured or harmed in what happened, but extreme end of the offence which I was likely to be charged with was potentially a custodial sentence. So my life and career as I knew it was effectively over. And that first week or two was absolutely terrible. And I was continually in a place where I wasn't sure whether I was going to finish it off, complete the job. But one thing changed for me, and that was when I came home from hospital, and my little son, who wasn't school age yet, who was really excited because he wasn't expecting to see Daddy home. And just that connection with him when he was so happy to see me, knowing nothing about what had happened, but was just excited that Daddy was home. Something in that interaction and that eye contact made me feel that I needed to at least give this a try for his sake. And if there's anything out there which will help, which will make me better, I need to at least give that a try. This was no longer about me protecting my career, my reputation. That was all gone. This was about me deciding whether or not I wanted to live or not. And that little interaction and the anger which turned into relief in my wife, and all those kind of things which you completely forget about when you're in that place, because it all becomes about you, it all becomes internalized, and all the people around you aren't really seen as support. The nasty, horrible thing about all mental illnesses, I think, is they make you do things which are completely against what helps you get better. They force you to isolate yourself. They force you to conceal it, the stigma and shame associated with both depression and, in particular, attempted suicide. And then if you add into the mix a substance, in my case, it was alcohol, other people have turned to drugs, and in effect, you end up criminalizing yourself through your health. There was still, and still to a degree, is this stigma for people who don't understand certainly the addiction and substance problems which are rife, I think, in medicine, are the fact that people still see it as a bad behavior. And you've got, on the outside, I would say I had everything, but I had a house, I had a wife, I had 2 wonderful children, I had family. My career was actually pretty good. I was kind of in that kind of situation where I was being fast-tracked towards probably medical director, if that's what I kind of wanted to do, and probably may well have got it if that. But at that stage, everything on the outside, I just won a 7-year contract for our service in addictions, which was at that stage unheard of, and we were still one of the few NHS-led addiction providers within the UK system. Only about 50% of services are still NHS led and owned. So, you know, there was nothing on the outside which said that my life was crap, but actually inside it was. It was a shell. I was surrounded by everything I wanted or needed, yet I was completely alone, isolated, and hated it. And that was the bit that was the depression. And that was the bit that was only teased out when I realized that this isn't me because I'm a drinker. This isn't the shit sorry, bad language, I've created for myself. There's a reason why I'm taking the substance to self-destruct. It's because I can't do life. And I can't do life because I can't find a purpose to it. And all those things which, you know, the normalcy of being happy, I'd never really experienced for a long, long period of time. And I did seek help, and I reached out initially to primary care, and I started seeing my local GP, who was wonderful. And I started on these sugar tablets, which we give out, called antidepressants. And after feeling absolutely atrocious for the first week and thinking I was getting worse, something clicked. And all of a sudden, for the first time in my life, I saw the world in Technicolor. It was like, I've described it to people, it's like if you've always watched an old tube 5x4 TV or a really low resolution screen, and you just think that's what TV is. But then all of a sudden, one day you wake up and there's this big, massive widescreen TV in front of you with surround sound. And it's like, hang on, is this what everyone else sees? I've never seen this before. And there was a vibrance, and eventually I started getting emotions back, good as well as bad. And increasingly the will and the fight in me started to grow. And I took all help that was offered. I reached out for support. I didn't lie. I didn't get angry. I didn't blame people for messing up my career. I didn't get angry with the GMC or anyone who had reported me. They were just doing their job. Their job is to protect patients and protect their reputation. And if you've got a doctor who tried to kill themselves and was under the influence of alcohol, then whilst they're on an on-call shift, I put them in a position where they had to make those choices because I didn't manage my health or couldn't manage my health. But now I knew I had to do something. And that was the start of my recovery. Firstly, around stopping the drinking. Secondly, around getting on some antidepressants and having the humility to admit that I was ill and I needed help, and accepting that, embracing it, and progressing with that. And as my mood improved, life started getting a little bit easier. All those horrible things which were there as part of the GMC process did go away. Eventually, I'm now my conditions have all lifted, and I did have a driving ban near the time, which has now been lifted, and I'm able to drive and everything. I'm happy with life. I'm doing things. You know, I sing in a choir. I know that's not particularly ambitious, but it's all right. I'm involved in local recovery networks. I'm supporting things like this, all of stuff which I'd never have the confidence or ability to do, because I decided to give life a chance. And for the first time, I'm living rather than just surviving. And that's, see, I told you I ramble, Sri.
No, Deep, thank you so much. It's not easy to talk about mental illness, and we are really grateful. some students have really interesting questions. Is it okay, Deep, if we take a couple of questions, please? So, good afternoon, Dr. Sirur. Thank you very much for such an honest and personal talk. It has been fascinating to hear your insight. Could I ask from your experience how you might approach a conversation with a fellow medical student who is suffering from alcohol or substance addiction?
So I think one of the challenges, and this is the clear thing, I think what's really important is in terms of your own feeling and your own moving forward, is alcohol or substances and mental health are really quite tricky. It is very difficult when you're in that place to work out what led to the other. I'm preaching to the converted in Sri, who probably in her liaison days, that's a big chunk of what the types of decisions we have to make in those circumstances. And certainly with my professional head on, a lot of my day job is delineating those risks and how much are treatable and how much is a behavioral thing which needs to be managed in a different way. But actually, the first bit is making it very clear to people, which is why I'm doing this. Problems with drugs and alcohol are not bad behaviors. They're not, and within medicine, within the GMC, people don't get into trouble for the fact that they've got drink problems. People get into trouble because those drink problems or drug problems are having an impact at work, and part of your GMC obligations are to manage your own health. So that's why it's important. If people have problems, I think alcohol is something which you should not force people, and people will not get better because they are told to, because it doesn't work like that. This isn't a bad behavior which you can't just stop. If you could, you're all intelligent people. You would have done it by now. There's something else going on which makes that tricky, and that is recognized, and that needs specific targeted help initially to deal with the problem. What I would always encourage people, so if you see people with problems, reach out to them in a non-judgmental way. There is support out there through PHP, who are much better now. There will be support through your deaneries, through your trust, where they will see it very much as a health issue that you need support with. Your job is to then engage with it and accept the interventions and have the humility to give them a bash. If you're stuck in a mindset where the problem is everything else other than the fact that you're self-medicating, or you don't see that you're self-medicating and why can't people leave you alone, you're going to have difficulties because your mind isn't in a place to address that. You know, my mental health wasn't why I had a drink problem. I had a drink problem because I was a drinker. Drug people have problems with drugs because they take drugs. Now, part of the core bit of managing that is if there is underlying stuff going on underneath, be it social, psychological, in my case, mental illness, you get the treatment around that, but you see that as a separate but interlinked problem. Because there were periods when I was not depressed and I drank like a fish. There are periods where I've been now where I could feel my mood slipping and was lapsing into an early relapse, which was corrected with a medication tweak. And at no point during that did I feel the urge or the compulsion to drink. So these are two separate problems. And the problem with alcohol is it never, or if you have a hard end problem with substances, it's a lifelong thing. There is no magic thing, as I found to my cost twice. There's no magic number where 4 years down the line, 5 years down the line of being dry, it is no longer a problem. It's something that you always have to be aware of, and you always have to have the tools. You always have to be open, honest, and sometimes that's hard, which is where mutual aid and support comes in. And then it's about treating what the underlying issue is. What I would say, and I've heard all the time, is anyone who's there, what ideally you want to put yourself in the driving seat. These things are much easier to handle for you if you come forward. If people reach out and say, have you got a problem? The easiest and best thing to do at that stage is say yes. I'm happy to have help and I'm prepared to engage with that help, because then you're showing insight, then you can get the support you need, and then you're in much more control of the situation. As I said, there is nothing about mental illness which would stop you being a doctor. There is nothing about having a problem with alcohol that would stop you being a doctor, as long as that doesn't impact on your ability to do your job and you don't put yourself or others at risk as a result of it. You know, people with drug problems aren't who have problems with the GMC and regulators. It isn't because they have a problem with addiction. It is how they're getting the substance. And unfortunately, there is an issue that as a doctor, if you're taking an illegal substance, just by taking it and fessing up on it, you've done something which would be of interest to good medical practice, because you've kind of taken the law. If people have resorted in extremis, this hasn't happened to me, that you're actually taking stock or writing or self-prescribing or nabbing things off trolleys, then you're in another issue, because that'll be in a disciplinary thing. Mental illness doesn't mitigate or excuse stuff that you've done that is wrong. What it does is it gives you an explanation as to what that's about, why it was about, and give you the tools and an understanding to make sure you don't want to happen again, and picking it early. So my encouragement is do not hold this stuff. There is nothing special about us. The only thing special about us is sometimes we think we're too special. You know, if there's one thing you take home from today, is if an addiction psychiatrist is actually, I've been told, quite good at my job, who has treated countless people, diagnosed countless people over the years, couldn't see it in themselves. This isn't about stupidity. This isn't about lacking the knowledge. This is about the fact that your brain will take you to a place where you won't see the problems and other people will. So you need other people in there because they will pick it up. I listen to my wife if she picks up that I'm a little bit irritable compared to normal, or I'm not as present for my kids, because I don't see that. Other people around me do. And it's about surrounding yourself with people who you trust, who know how you're doing and where you feel safe to tell people what's going on. And if you do that, then things will work out. We talk in some circles about the yets, all those things which happened to me. If I, looking back, had had the humility or insight to recognize I needed help at the early stage, those yets would never have happened. But unfortunately in my story, it had to get to that point before I was ready, willing and able to really address the situation. But by that point, it was mission critical and came with a whole wad of stress and additional anxiety, which in and of itself would be enough to send people over. So if you don't feel comfortable having those conversations, then talk to other people, because these are things which you need to do. But it's about letting people know that you know, and it's okay to talk about it. And would I say it's normal? It is normal for people to struggle. It is normal if you're doing a job where you are under-resourced, there's a lot of pressure on you to get things right. If you come from a high-achieving area, and when you're used to succeeding, you're setting yourself up in an environment where you're going to always see yourself as not as good as you should be, and that creates a problem. You know, we're doctors, we're not gods. We can help people manage and save their own lives, but it is a profession at the end of the day, where we hope that our interventions will make a positive difference in people's lives. We don't decide whether people live or die. We have no power over the funding structures and the support infrastructure that's around us. What we do have control of is who we are, what we are, and being open and honest about whether we're struggling or not. And part of that might be having a discussion or decision as have you actually made the right choice? But most of us find that we have made the right choice, and don't rush into saying you're rubbish or feel like quitting because you're finding it hard. It is hard. That's why it's hard to get into. That's why you have to do an awful lot. But it is also one of the most rewarding jobs you can ever do. And it was only after I was at risk of losing it, I realized how privileged I was to be able to do a job where I'm paid a decent wage, where I help people, rather than doing a job where I get the crumbs off a big table because I'm making a rich person even richer.
Thank you so much, Steve, for highlighting how it's important to recognize and ask for help when somebody is struggling, because when the treatment is given at the right, help is given at the right time, people will.
Yeah, and again, I'll reiterate, I wasn't in trouble with the GMC or the law because I was ill. I was in trouble because I didn't recognize that illness. I didn't do anything about it, or the circumstances were such that I got to a position where rightly I wasn't doing my duties as a doctor properly, and I could have potentially put people at risk, and I was, and part of that was I was involved in a criminal justice situation. But from a broader point of view, and this is to be supportive to people, the GMC are actually very good, I think, in my experience, of delineating if you are involved with things which have a potentially criminal angle. Not necessary if you've got a health problem, if everything is clearly linked to your health, they are much more sympathetic about that element of it. It doesn't mean you get off scot-free, but they will be more sympathetic to the circumstances as to why that criminal justice related event happened, and if it is clearly linked into your illness as it happened, as they took the opinion of in my case, their view was very much, well, there is a criminal justice process, their job is to punish. There is an employer who you work for, it's for them to decide whether you breached or done anything in the context of employment where they need to consider disciplinary or whatever, and our job is to make sure you are, if and when you are practicing as a doctor, that you are safe and you're not putting people at risk, and you can recognize when you need help, and you've got support infrastructures around you which you will access, and that we can trust you to do that.
Thank you, Deep. I would like to ask attendees one question, and then I'll take one question from the Q&A chat box. I want to ask attendees, so in your medical school, are you aware of way to get help if you think that you or one of your friends are struggling with either mental health or with substances? Like, do you know where to seek help? Okay, you can think about this. And there's a question here, Dave. Where did this feeling of purposelessness come from throughout your medical school career and medical career that made you feel as though you could not continue?
I don't think it was about, this wasn't necessarily about medicine. I think one of the things which, there are various, and I didn't go in, one of the things which these are things which will come with time. My purposelessness, I suppose, I think there are various things along the way which made things a challenge. I think probably one of the things, in a good way, but also a bad way, was I was fairly fixed in my career choice. So I had to do an awful lot of stuff in medical school, which I wasn't particularly interested in. There was a whole lot of physiology, anatomy, and various other bits and bobs, which weren't really that relevant to what would be a jobbing psychiatrist. You had to know it, you had to pass the exams, you had to do this, that, and the other. But a lot of the stuff I was doing was a means to an end stuff. So I didn't really have that motivation I wasn't excited about receptors, and I wasn't excited about the pathology of the big toe, or, it sounds, there'll be people who are envious now when I said, I've assisted in AAAs, and the number of times where I had to avoid because I didn't really fancy doing appendices at silly o'clock in the morning. As students and as junior doctors, we had that exposure, but because I was never really into that side of thing, those things were always things I had to get through. So I never really had that, isn't it great being a doctor? Because that only really kicked in when I started psychiatry. And by that point, it wasn't actually about job and career, it was about me. And, it was about, why aren't I happy? And that was nothing to do with my job. That was about me and my life and how I approach things, and various things looking back around anxiety, stress, which I'd mismanaged, the elephant in the room, which I'm much more aware of now that I didn't, that despite going to a posh school, despite having this wonderful accent that my father paid for, my skin is brown, my name is foreign. That comes with stuff. You know, people who are of a certain age in this country will remember that routine was being called the P word. Routine was being chased around out of parks by skinheads. You know, I'm not minimizing what people are experiencing now, but this was very much reality. You were made to feel that you did not fit in this country, you did not have a place in this country, and you had to accept the shit that went with that, and you had to know that you had to work 3 to 4 times as hard to get the same as me if I were white. Now, I don't want to make this into a political or race thing, but for me, that was an issue, you know. And because of that, from a well-meaning point of view, I felt in a pressure cooker environment where my good was never good enough, you know, and I struggled with that. And that's the bit which I really need to be thinking about and encourage you to think about. Your good enough is just fine. Yeah. People will tell you if you're suboptimal at what you're doing. Yeah. We put too much pressure on ourselves, and we listen too much to other people who seem to be experts in our lives. We know our lives. We know what we're about. If we don't, it's a growth process. I didn't know who I was at 18. It's only now that I'm 50 and I've got all this toxins out of my system and I've got my mental health in a place where I feel comfortable and confident to say things, do things like this, go up to people. You know, am I the type of person who'd be mates with the Dean of the Royal College of Psychiatry? No. Would I feel comfortable being on the faculty exec of addictions? Would I go up to, I don't know, hypothetically, A-list individuals quite comfortably and say, "Hi, how are you doing? I'm such and such," and have things to talk about? No, that wasn't me. I needed drink to do that, and I needed confidence that I can do those things quite comfortably now. And now it's not about getting me to say stuff. Now it's about making me shut up, isn't it, Sri? So I think medicine can be all-encompassing, but it isn't you. You're a person who happens to be a doctor, and the problem is you have to work that out, and you have to go through a journey of knowing who you are, developing who you are, and the key to anything in life is making sure that you don't compromise too much of yourself to get something else, because the secret to misery is having to try and pretend to be someone you're not because it looks good on the outside. Now, what was lucky for me is when my mental health improved, I realized I had everything around me and I just hadn't spotted it or seen it. For other people, it isn't that straightforward. And I've had a lot of luck along the way. As I've said, I have had good employers. I've had a good working relationship with senior people within the trust. I passed the good egg test at an earlier stage, which meant people wanted to help me rather than were using it as an excuse to throw a book at me. So I'm not naive that it's not always as easy for people, but you know, at the end of the day, we do a job. It is a brilliant job. It is an all-encompassing job. It takes up your life, but you need to draw that line that you are comfortable when you're a doctor, when you're not a doctor, and how that translates. I find it easier because my values are more values of somebody who I would like as a doctor, and trying to live those in the outside world, rather than putting my doctor mask on or my doctor outfit face on at 9 o'clock, go through it, get through the day, and then going back to being me. It becomes easier when you come that, but that is a lifelong journey, and will take time.
Thank you, Deep. It's not easy to have this conversation. Thank you so much for coming and sharing about your experience and helping our students to ask for help if they're struggling. Thank you. I just wanted to ask the students who are here, you know, we are really keen to write up this Dr1in4 program as a book chapter for one of the books we are editing at the moment. So if any of you are interested, please do contact. I think it's really important for us to share this work with other people, because it's being a medical student is very difficult. I think it's really important to have these sessions like this all over the world, so that students feel more comfortable talking about mental illness, so they can feel confident that, even though somebody has mental illness, then they get help, they can get better, they can continue to work. So it's really important to send this message. So if there are a couple of students who are interested, we are happy to support you to write this book chapter. Now I will hand it over to Cookie.
Thank you very much again, Deep, Sri. This has been fantastic, so eye-opening. Thank you so much for your honesty and candor, for sharing such a profound.
And thank you, Sri, for not
story.
falling asleep. It must be about 3, 4 o'clock in the morning, and I have been told
Yes.
I have a voice which is quite good at putting people to sleep.
Absolutely. Yeah, as Sri said there, I have put the contact details for us in the link. So if you're interested and happy to contribute, or indeed if you have any queries or questions about anything we've discussed today, or Doctors in Distress as a whole, do please use that email address to contact us.
Could I also make a quick plug for something which has been really, really helpful on my journey, which is an organisation called the BDDG, British Doctors and Dentists Group, which is specifically a group of doctors and dentists in recovery who support people. It's a self-referral system. I can give people contact details, or maybe you can post how to do that. They're all,
yes.
and it's open to medical students as well. It's self-referral and it's confidential.
Brilliant.
Fantastic. Yeah. Thank you so much, Dipanshi, for your interest. And it's really important. Sometimes it might be a bit difficult for one student to write the book chapter. If other students are interested, feel free to contact us. We can, work together as like a team and publish this quickly.
Yes, please do. And as I say, this is being recorded, and so we will be editing, publishing the link as soon as we can. Thank you all so much again for your time and contributions. I wish you all very much well with your careers and your lives in general. So thank you very much. Take care. Bye.